Dear friends and colleagues in global health, my name is Jeanette Magnus, and I'm the director of the Center for Global Health at the University of Oslo. The Center for Global Health is an initiative of the Faculty of Medicine as part of the 2030 Agenda to meet the Sustainable Development Goals. The Internet will also be essential for the implementation and monitoring of the Sustainable Development Goals. The next step will be to see how the goals can become reality in an increasingly digitalized world. The last 20 years, the concept of health literacy is becoming more and more important. Personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. On behalf of the Center for Global Health, I'm excited to welcome you to this webinar and to introduce Professor Josef Noll, who leads the digital cross-cutting theme and is our moderator for this session. Since joining the University of Oslo as professor in 2005, following his career at Siemens, Telenor, and European Space Agency, Professor Noll has worked on digital transformation, including digital tools for health projects. Please, Josef, introduce your impressive panel of speakers and take us through this exciting seminar.
Thank you so much, Jeanette. And I have the pleasure to be here with my colleague, Jonathan Moringani.
Greetings to participants.
So we hope that we can guide you through this digital session. And before we start, I would like to mention some rules for this event. The webinar will consist of short presentations, about 10 minutes, such that we have time for an in-depth interview with the presenters, and then follow with some 5-6 minutes of open questions. The reason for that is that we want to start the dialogue and invite you all up to finish then at the end with an open question and answer session, which I will then share with Jonathan. One of us will do the online part and the other one will do the digital part. So we hope that we can engage both you as our participants and our speakers during the question and answer sessions. And by explaining the seminar series, this is the first kind of series. We really see that we'd love to bring across the message of that health information for everyone, health information empowering everyone, is one of the topics which is really burning. And what we expect from the outcome is that we get the speaker's perspective from the different continents where we have worked or where we got the input, and then bring that across in the last question and answer section into preparing follow-up seminars and establishing the basis for policy papers on strategies for health literacy. In that case, please use actively the Q&A. Either Jonathan or me, we will follow and moderate. So without any further delay, I'd love to introduce Margaret Kaseya. She is Professor of Health Policy and Director of the Research and Programs of the Tropical Institute of Community Health and Development, TICH. I had the pleasure of having discussions with Margaret earlier. And I'm so impressed about, Margaret, about your ability to not only look into the challenges of your country, but also in the challenges of Africa as a whole, which is part of the TICH. So without further delay, I'd love to open up your presentation. And I hope you now see the screen of your presentation. Correct?
Thank you. Yes, thank you, Joseph.
And then please start.
All right. Thank you so much, Joseph. And I'm really privileged to be part of this conversation, which I think is really important for us to be having at this time in this decade that we're having, and especially from the African perspective. Next. I'll be using the word next for the next slide. So, as we might know, Africa's population is mostly in the rural areas. About 60% of the population is in the rural areas. So when we talk about health literacy, we're really focusing on this particular population. And definitely we know that for us to achieve SDGs in the continent, we cannot run away from digital technology. I'm glad to say that Africa is really connected. We have smartphones, and the use of smartphones has really doubled in the last few years, and the penetration rate is almost half. So there's a growing subscription rate of smartphones, and it's not who has the smartphone, but who has the latest smartphone in most of the region in Africa. So we have to look at what kind of literacy do we need to have if our population is rural, but at the same time, they have smartphones, some don't, some have. It's a growing field. So how do we tackle this situation? Next. So when we look at health literacy, if you look at my next slide, this definition has already been mentioned. It's helping people to get information that they can use for themselves, that they can use to help their own health and that of their families. And according to research, communication of health follows certain processes. But as a researcher, I would say that most of the research that has been done in communicating health uses, shall I say, a Western perspective. So there's really need to look at the context of Africa and to say, how do we communicate health? What kind of literacy regarding health is needed? And if we look at the traditional way of communication, I remember in my earlier years when I was a young child, we used to sit by the fireside and we'd be told health issues. For instance, the first talk that I had on sexual and reproductive health followed a cultural way of communicating, of alerting me that if I wasn't behaving properly, I might get pregnant, I might get sexually transmitted diseases, but it was done in a context that was very African. And as we look at digital technology, are we looking at whether it is in context, whether the information we are providing is in context in the African continent? And I'll explain a bit more on this. Next one. So when we look at e-health or electronic health information, currently there's quite a number which all of you know. There's telehealth, there's telemedicine, there's electronic health, record systems, which in our system in Africa is mostly used by ministries of health. So mHealth includes smartphones that I've already mentioned, and it can include very complicated items. For instance, you can have a bracelet on your hand which can communicate health information. So according to WHO, mHealth really consists of smartphones as a basic structure of relaying health information to patients and following up. But mHealth applications in the African continent, what does that mean? It's fine for WHO to cite its definitions and to cite guidelines, but what happens at the end of the day in the ordinary households that we have? Next. So mHealth applications, when we look at them, we are talking about creating awareness. Yes, we can create awareness using cell phones, and this is happening in Africa. For instance, during the COVID-19, community health workers were able to get information on what to do. What is the next thing to do? Do you wear masks? How do you visit the households? What about hand washing? They were able to get this kind of information on their phones. Not all of them had smartphones. So what did they do? They borrowed from their neighbors. They asked the teachers who are a bit more highly elevated in terms of income. They're able to get information, either short message information or information from the internet. So the use of mHealth using smartphones is on its way to be used for diagnosis, for patient follow-up, and so on. It can even be used to train community health professionals. In our instance, in Africa, if you read about COVID-19, which is the latest example of what happens in a pandemic and how does digital health help in such a situation. We saw that community health workers were being trained using messages that were passed through their phones. They were brought together, and as they went to the households, they were able to record data on who they had seen, what was the condition of that person, what did they advise as the next step. And some of this information was loaded up into the national health information system that even guided the country on where they were in terms of the epidemic and what needed to be done. And at some stage, our Ministry of Health resolved that enough of ventilators, enough of admitting patients in the hospitals, let them be taken care of at home. And at home meant community health workers at home with their phones on alert and receiving information. So mHealth application in Africa is possible, has been done to certain extents, but my process is that it should be in context. We should look at the kind of information we use. We should look at whether those people can actually get the information that they require. Next. So I've mentioned before the remote monitoring of data being collected, SMS. So this is the most popular that is found in most African countries. And why? Because to send a short message over the phone costs minimal. It's not like going into the internet where you use a lot of bundles and you have to pay for them. So messages through mobile data that is reasonably costed can be used in real time to alert populations, to alert people, to alert households on what is happening. And this has been seen in the case of Ebola, in the case of COVID-19, and in the case of outbreaks. Recently, we had a cholera outbreak in Kenya. And again, the use of messages over the phone proved to be very, very useful because the population was in a very remote area. And the only way that they could be reached with immediate real-time information was through the smartphone. So mobile phones are really the in thing for Africa when we look at issues of digital technology. So the next one, why does it increase? Why is it so popular? Why is mHealth so popular in the African continent? I think it's because of mobiles have been used not just for health, but even for business. I'm able to connect to a farmer, to a buyer, to a seller in real time. I can get the cost, I can weigh the cost, and I get the best buyer. So it's popular beyond health itself. And I think this is why most of the populations have really taken onto use of mobile technology information. Now, about the coverage, that's questionable, and it's one of the challenges that we have in the African continent. While we have really used technologies for very important information, HIV and maternal health and other issues, connectivity is still a problem. So health literacy, the next slide. We know as public health practitioners, health literacy is really, really important. Without high levels of health literacy, the health of the household is compromised, management of one's own health is compromised, and we know that. But now we are adding on the component of digital health literacy. And this is where now the issue comes in. How far can we have the populations digitally literate? And this is where I go back to my theory that the frameworks we use and the research that we do is so confined. We are not flexible enough to look at how the traditional way of communication links to digital communication. The next one. So the challenges, of course, in our context in Africa, finance. None of our, at least most of the countries, have never really adhered to the Abuja Declaration, where 15% of their health budget is supposed to go to health. In most countries, it's around 6%, 7%. In Kenya, we are 6.5, even less. And then the other challenge is just connectivity. So for now, just to make sure that I don't switch off, I have like 3 sets of internet connection right here in front of me. So if one goes off, I can quickly connect to the other one. Connectivity, poor internet connectivity, the poor quality, and also just the equipment is not readily available. So those are some of the challenges that really inhibits higher levels of connectivity in terms of digital technology. However, we know that some of or most of Africa's problems in reaching populations and so on, reducing disparities, having access to healthcare, and even reducing the cost, this is where digital technology can come in. And even as we look at SDGs 2030, we cannot run away from the use of digital technology. And I pose here that for rural populations, let's look at the community volunteers and see how we can really strengthen their skills in better use of even the basic phones that they have in terms of the content that is passed through these devices. So my last proposal is that we just have to collaborate. We cannot do this alone. We have to look at who are the players out there, who are the key stakeholders, and all of them are there. If it's the government, if it's the communities, research institutions, those who are making these technologies, NGOs, the private sector, if we can find a forum where we can all come together, that's in my next slide, and each one comes in terms of their own expertise and contributes to this whole explosion of digital health literacy in Africa. So thank you very much.
Wonderful, Margaret. Thank you. I'll give you a virtual and then a real clap. I really love the stuff. I really was triggered by your first point, which was the point of sitting at the fireside and being learned with the health issues. Can you explain more about what this context means of this kind of discussion? I mean, how did it influence you? How was your path from, from sexual health education, either before or after the contextual setting, to where you are now?
I think it was a very relevant context because we would be sitting around the fire with our peers. We were the same, almost the same age mates. And then we have our auntie or our grandmother, words of wisdom coming from this person. And it's a relaxed atmosphere. It's in the context. We are eating, relaxing, eating roasted maize. So the information is not threatening. It is delivered in a way that it's not given as a rule. It's given as a way of life, that's how things are, and each one of us is expected to conform. And I kept on remembering these sessions even later on in life. The messages would come back, don't do this, remember this, if you do this, this might be the consequences, because the learning was so conducive. I think that's a difference.
If you like to take that and transfer it into the digital space, I mean, digital is just, sorry, I'm professor at the technology systems, and what I hear about ChatGPT and so-called artificial intelligence, I don't call that really intelligence, because like the sensing, the smelling, the sitting together, the atmosphere, that is nothing what we ever get through this square screens in our sessions. So what I'm out after is how would you actually, and I want to share with you, how would you bring this story of your community out in digital? Do you have any ideas?
I think we can use a blended version. So we may have a standard content, which is like what we're having now, but then push that now to the community level where there's real dialogue, there's real interaction, face-to-face. I think both can be done so that one doesn't lose the best of digital technology, nor the traditional way of communicating health. The two can be blended in context.
Yeah, and if you see the pathway, I mean, you were extremely good in basically showing us the challenges. You had the suggestions. You had this input to the community volunteers. What would be your pathway for health literacy in Africa or digital health literacy in Africa?
I would move along in the how would I call it? Digital health is really moving along a path and sometimes very fast. I would move along with that, but I wouldn't let go the community aspect. I'd bring them along and even have sessions where they can inform the format of digital technology. I think sometimes we tend to forget them. We come up with our best practices and we assume this is best practice for them. I would engage them at all stages of developing content, literacy, health information, and so on.
Yeah, thank you. I think by this time we open up for the questions of the auditorium. I see that Oscar has a lot of questions. Oscar, Gabriela, can you enable Oscar to speak up with his question, because he had like 3 answers to it in the question and answers. So I think we start with that one, or suggest we start with that one. Or maybe, Margaret, if you can read them, like what he's saying, what would be an effective way to communicate the availability of new and hopefully financial accessible digital health solutions?
Oh, right. I think we just have to, as I said before, not working in our own silos, but being open to what is out there. So that, like, for instance, this forum, I think this forum is a way of sharing what is already out there and what is working. So I think we need to just be in touch and share what is happening so that we are not left behind in terms of the latest developments and lessons learned.
And we have a second question coming in from Elibariki. Hi, Elibariki. So good to see you live. And you are asking, what can you advise the governments to offer subsidies in the costs of mobile phone connectivity as a way on enabling sustainable solutions on reducing costs of connectivity to rural populations in Africa?
We can try. We can try and ask the government, but from what I know, governments have other priorities. Unless there's something in it that they can see that will immediately benefit government operations and bring the population together, it's unlikely that African governments will have a special fund or subsidy for internet. I think it's the other way around. They expect business to come in and to boost what government funds have available.
Oh, Margaret, I really like your open discussions. In the interest of time, I would like to swap position now and let Jonathan introduce, Monica and Edmund, and go to the second talk. And then I hope we can hear you again at the final question and answer sessions where we have some more topic. Thank you so much for now, Margaret.
Thank you.
Thank you. It's my pleasure to introduce to you Professor Monica Sonnet and Dr. Edmund Rutter. So Professor Monica Sonnet is a professor at the University of Northern Carolina, And Dr. Edmund Rota is a senior health specialist at USAID. So without much ado, I'll hand over to Monica and Edmund to take us through this afternoon. Over to you, Monica and Edmund.
Thank you so much, Jonathan. Thank you, Joseph. Thank you, everybody, for putting this webinar together. It's my utter pleasure to collaborate with my colleague, Dr. Edmund, this morning. We have a little slide, different format. We have a very brief PowerPoint, some slides. We would be basically talking about the digital literacy, the impact, the relation, the different aspects of digital and health literacy with regard to tuberculosis, and with a focus in Tanzania. And then followed by the small presentation, me and Dr. Edmund will be engaging in some question answer series, basically using that format to educate and share the information with the participants. And at the end, if any of the audience or participants have questions, myself and Dr. Edmund will do our best to answer that. So, Dr. Edmund, you want to take over the slides, or?
Sure. And again, also thank you for having me here and for this excellent presentation. So like Monica said, we will just jump into a few slides and then have a little bit of our discussion among ourselves. So next slide, please. So I'm very sure this is perhaps familiar to some of you, but I just wanted to bring it right here. And thank you, Margaret. You set the stage for a lot of background in terms of digital literacy, but broadly for digital intervention. For me, I just wanted to place it within the tuberculosis and just to give you an idea how large the problem is. So whatever you're thinking in terms of this solution, think about one of the biggest killer, one of the infectious killer in the world. So tuberculosis, this is from the last report from the World Health Organization. You can see it's all over the place. What this means in terms of the digital solution, digital literacy, is if you're going to tackle it within the TB, we're dealing with the multiple different health systems across the globe, because the high burden countries, they're in Africa, they're in Asia, they're different level of health system, they're different health level of technology penetration. Margaret really set the stage for Africa. We'll drill down with an example of how that has been applied, but I just wanted to make sure that this discussion does not get out of this big context of some of the biggest problems we're trying to solve. Next slide. Still on that point, TB still kills millions of people. WHO gave an estimate, but I think what is also important, we just came out of the COVID pandemic. In the TB community, the impact of COVID on the TB disease has been really, really hard. And one of the most important thing and relevant to this discussion is because we had all the communities and patients unable to access care, unable to receive the information that would help them to go to a nearby facility. So COVID had not an impact on the provision of health service delivery, but also the ability of patients to receive information and to access the care that they need. For me, those are very, very important aspects relative to this discussion. Next slide. The other point that I wanted to bring to this discussion is very, very important when you talk about digital technology. When you talk about digital health, we place it within, patient-centered. So for tuberculosis, we have been doing a lot of this patient pathway, really assessing the patient journey and their experience from when they have the disease to all the way to when they get the treatment. And if we don't support the patient at their household level, if you don't support the communities in which Margaret mentioned about the community health, we have a lot of experience of using community health to reach the patient with the tuberculosis so that they can access the care, but also they access the information that's empowered through their treatment. So everything has to be placed in this context. For us, it's very, very important. We look at the patient and placing the technology, placing the digital solution, whatever that is, within this pathway so that we can empower our patient. Next. I also wanted to share that if you apply this at a larger population level, one other way of looking, where do you want to deploy? How do you deploy some of those digital technology is along the TB cascade. From how do you, the individual patient who may not have the tuberculosis all the way. And in each step of the way, we have gap in the care provision, but we also have gaps in the type of digital health literacy, digital technology that have been deployed. So thinking about the solution has to take this into consideration, because the cascade not only look into the patient experience, but also they look at some of the gap in the health system. And I think that's the way we've been thinking around the digital solution. And that's the way we'll be thinking around the literacy in terms of tuberculosis. Next slide. So we'll be talking about one practical application of a mobile literacy, of a mobile application that has been applied in tuberculosis, and this was done in Tanzania. So it's called Tambua TB. Tambua TB is a Swahili word for I know your TB, or identify your TB. So this is a very interesting mobile application that use the broader, larger Ministry of Health platform to send messages to anybody with a basic phone, and through that, patient can self-screen. They can self-screen themselves and identify whether they have the symptoms and sign of tuberculosis. So it's a very, very important application that empower individual before they even know they have to be, but it also send information, raise awareness, it promotes self-screening, and create the demand for testing. So one of the biggest challenges in TB that we wanted to, this application was trying to address, is the delay in care seeking, is the delay that the patient know whether they have TB or not, so they can go to the facility and be checked by the healthcare worker. Once they do that, the health system get that information, and then they're able to follow up and make sure they get the right diagnosis and treatment. So by this application, we're able to empower patients to really know whether they have TB or not and seek care. Next slide. So very briefly, we just want to give you the result from that application. So Tambua TB was deployed in 6 regions, and immediately clients were able to self-screen, and they can see from the chart on the left side, close to 230,000 clients were able to self-screen themselves about TB, and roughly 160,000 of those reported to have symptoms and signs suggestive of TB. And this was the group that was were followed. And you can see on the right slide, the demographic breakdown of the individual who self-screened themselves and who had some suggestive symptoms of TB. So we'll pause here just to give you, for Monica and I to go into our second part of our discussion, but just this was one of the examples we wanted to share this morning. Over to you, Monica.
Thank you so much, Edmund. That was a wonderful, digital work has been done. So the next part of our presentation, me and Edmund are to engage like a question answer session where I would be asking questions or seeking information, and we didn't want to go the presentation route, so we wanted to engage in a question answer thing, and that would make the discussion a little more livelier for the audience. So Edmund, I understand you've worked a lot in TB, worked a lot in, digital technology. Could you share that, what are some of the challenges when we try to, implement digital thing, whether it's TB or anything? What are some of the challenges we see on ground when we try to use technology for TB?
No, thank you, Monica. The number of them, and I'm so glad with the Margaret presentation. For me, at the much higher level, in a number of countries, we don't have the right policies. We don't have the right guidelines. A number of countries are moving into developing whether it's digital policy, digital guideline, or e-health, m-health, stuff like that. But I think what that has done for a lot of these applications is you do have a lot of pilots. For me, I've seen a lot of pilots. We do so many pilots in digital literacy, in m-health solution, just end up being pilot. We don't get the scale. We struggle with this. They're all very successful, but there's no scale. So they end up just being deployed in one part of the program, one part of the country, or in a particular state. So I see that as another very big, the biggest challenge. The other thing, we still have a lot of, deployment. We're talking about digital literacy. We're talking about, patient-centered. For the one that I've seen that have been successful, they've been focusing a little bit more on the health system side of things. There's nothing wrong with that, but I think it cannot be limited to that. We have a lot of gaps. We have a lot of challenges within our community, and that will be very important. We also have tools and the digital solutions that deploy to empower our patient as well. So I can say that for now.
That was, wonderful. We understand that many pilots are done and they forget to scale up. Dr. Edmond, is there also a question, that there are too many pilots happening and too many, solutions coming out, but usually the solutions don't talk to each other? Or is there also a challenge when each of these tools are successful in itself, but they're not very, linked with the health department or the overall health systems that's making the decisions and that's implementing the policies? Could you shed some light on that?
Certainly. And I think that's where in terms of, if you have the policy, if you have the right kind of policy in the country and you have the right collaboration with the government, of course, with the government leading that, whether it's the Minister of Health or Information Technology, whatever the configuration may be in the country, I think that allows the deployment of one particular technology is within the broader ecosystem. What we are finding in a lot of our work is, yes, they've been successful in one particular area, whether it's maternal health, whether it's in surveillance, but the same tools are not able to talk to each other. So we don't take advantage of, the interoperability that could also help to get the scale, but also could also get into the cost and make it manageable. One of the things that we learned from the Tambua TB, what I like about Tambua TB was developed on top of another existing platform that was used for maternal and child health. So you could see that the Minister of Health did not want everything to start from scratch. So they took advantage of this mobile platform that they're already using for reaching pregnant mothers and children to build up on TB. I think that's the kind of approach that will be needed to overcome some of these challenges of being siloed, of being in the pilot, and not take advantage of the tools to speak to each other.
That's very good. I think that information is pretty helpful, coming from someone who has a lot of ground and, research experience. I also wanted to touch base on some of the success aspect of Tambua and, similar applications. Unlike other diseases, TB still has a lot of taboo. So how would you shed some light how the digital interventions help overcome the taboo and, access to care and, people identifying it, especially among the male population, where we see that, the reporting is not at times as par with other participants in the community?
No, I think this is exactly why this discussion is relevant in terms of, not only patient-centered, but also the literacy. If we empower patients, if we empower communities with a tool like Tambua TB, what we saw with Tambua TB, yes, for example, young male who are busy and able to access healthcare within the limited time that our health facilities are open, they are able within with their small smartphone, able to screen. They go through a number of, what are the symptoms of TB, and from that they know. Do you know how empowering that is at their household, in whatever place? So we were very, very encouraged by seeing how many of them took advantage of that and self-screened and were able to either seek care, or some of them didn't seek care. I can also talk about what was challenging about Tambua care, but the ability for them to self-screen, the ability for them to know whether they have TB or not TB and make decisions around that, I think that was the most powerful aspect of the tool. Of course, from the health system perspective, TB being an infectious disease, the earlier we can identify them and interrupt that transmission, of course, the better for overall control.
Thank you for sharing that, Edmund. I also wanted to ask you a follow-up question. When we are talking about this digital interventions, especially for a disease like TB, which has a lot of taboo, could you shed some light? What should the future technologies or future applications focus from the patient's perspective and the health system's perspective?
No, thank you for that question. So for me, I think we're dealing with health systems that have a lot of challenges. These are very complex systems. They're very overburdened. The healthcare worker in general has so many things to deal with. So I think whatever system we're going to develop it has to take those two perspectives. From the health side, does it make it easier for the healthcare worker? Whether it's a healthcare worker at the lowest health facility, whether it's a community health, does it make it easier for them to do their job in terms of collecting information, supporting the patient, whether it's supporting adherence or finding them? I think that one big aspect. On the patient side, we have to make it easier for patients to seek care, identify the type of information they need. Typically in TB, the treatment is very long and a lot of patients need a lot of support. Does it make it easier for them to adhere to their treatment? If we can develop tools that support the patient and at the same time support the health system, I think that's where we find a lot of gap. The tools are nice, the tools are good, but they're just good for us. They're not good for the patient that we want to empower and help. And of course, like you said, if anything that improves stigma, make sure that they can access in a way that they're not made worse off. I think those are the type of tools that we should be developing or deploying if they're already out there.
So I have two more questions for you, Dr. Edmond. One is, with so many pilots, with so many interventions, with so much work being done, what is, if today, 2023, we were like, we want to move forward in a more efficient, more cost-effective manner, what would somebody who has worked in the field for so long, what would you tell the researchers or people working in digital area? What is one or two things that practitioners would look forward to, bridge the gap between diagnosis, treatment, and adherence about TB?
For me, policy is very important. I think Margaret touched on a number of aspects around collaboration. We have to collaborate, let the government, whatever ministry it is, at that level. If we have a broader policy that describe how we can collaborate, I think that's one big area. We don't need to recreate wheels every other time. I think that the aspect of interoperability, there's some really good tools that are already out there deployed. They may be in one particular disease area, they may be in malaria, they may be in TB, they may be in maternal health. We have to take advantage of some of the already deployed tools, really working well to make sure that they speak to each other. The other thing for me is scale is very important. I can't repeat this enough. I have not seen any digital application or tool that has not been good in one aspect or another. But they're only good in a small or limited scale, then they're not good for our population, but also for the system as well. So I'll think collaboration at the higher level, making sure we have the right policy, but we have the leadership from the government, or the Ministry of Health, which tend to bring all the different disease program. I think for me that would be the key.
And my last question is, Dr. Edmond, could you shed some light? Because of COVID, that has had its plus and minuses. In some way, COVID pushed back, the work that was being done in HIV and TB. But on the other hand, policymaker and health systems professionals have said that, there is a lot to learn from the way COVID pandemic was managed. And, there could be a lot of things that could be learned from COVID pandemic. Could you shed some light? What could TB endemic countries, now that hopefully everybody's getting back to the gear, what would you say can people learn from the management of COVID pandemic with regard to managing diseases like TB?
No, thank you, Monica. So the TB, we both suffered from the patient perspective, the fact that patient couldn't access the healthcare, the medication, until people made adjustment, that was a problem. But I think we also benefited a little bit. COVID demonstrated that you can actually do a lot of things using this application to reach people, to reach patient, to reach client, wherever they are. So mobile phone, even if there are no system, people may have experience, WhatsApp, all kind of things. We were able to reach TB patient and make sure they get their medication just by tapping into some of those, applications that were out there, not necessarily configured for the disease. But the one aspect that we learned that is critical for TB and other disease was surveillance and the timely data collection. COVID demonstrated you can do that. You can do that in a very successful way, because there was attention. There was also people who, healthcare system that was given the resource and given the attention to collect that in real time. And the type of decision you can make with that type of decision data, I think was very incredible. Yes, we do have some system that collect that, but it's on either monthly basis or quarterly basis, which doesn't lend itself really well in terms of the decision making. So if we can do that in COVID, we should be able to learn from that and build it for TB.
I'm sensitive about time. We have a few minutes before we end our session and open the question and answer. Dr. Edmond, we have talked a lot about Tembua and other things that have worked. I also understand there have been some programs like ECHO, they were implemented with, all fanfare, but there were some challenges, that did not meet its desired goal. Could you shed some light on what happened and what future technologies could learn from these challenges?
No, thank you. So for just for very brief, maybe for our audience. So the ECHO is one of the technology that has been deployed quite a lot, not only in TB, but in many other areas. And this platform use video conferencing to communicate between different healthcare workers at different health system levels. It's a very powerful platform, has been very successful in many of the countries that I work and we work. And even in COVID, one of the because that system has been built for some time in a number of countries, when COVID came, that system was able to be deployed in a very appropriate way. What we're able to do with the ecosystem, if healthcare provider between the different, for example, the district medical office or the regional or the Minister of Health, they'll be able to reach healthcare worker everywhere where that platform is operating. They were able to get not only the report, but also in some cases discuss some of the healthcare, patient challenges that they're existing. So that's one platform that we've seen that has been successful. It is challenging just because it takes a little bit of time to deploy it and set it up. But I think once you have it, we want to have it in place in a few countries, it's relatively easy to maintain and use it for any disease condition. This is not a particular disease specific. So we've benefited from places where this was in place already. Thank you.
I think being sensitive to time, I will just try to, present a 1 or less than a minute summary. So what me and Edmund have explored today is that, there is a lot of scope for digital work in TB. However, listening to an expert in the field, different from what we researchers do on our computers, what I'm hearing is that there needs to be pilots that can be scaled up. There needs to be interventions that talk to each other. There needs to be linkages between the patient and the health system's perspective. And this is what we are looking forward in the future, that, there is scalable technologies that talk to each other. And, that mainly there should be connections between the patient and the health system side. Did I miss anything, Dr. Edmund?
No, I think you captured it well. Maybe we can get some, if Jonathan or Joseph has any comment, question, or from the audience, we're happy to take any at this time. Thank you.
Yeah, thank you. Thank you very much for the interesting presentation, and also for the question and answer that Monica that you're doing, Monica. That's very interesting. So that makes my job pretty much easier. I only have 2 questions for both of you. So Dr. Edmund, you did tell us about the Tambua TB app, which I think is very innovative and very interesting. And when I check, I see that in Tanzania, where it was implemented, about 25% of the population has got access to the internet, which means obviously not necessarily everybody was getting access. But since this is a digital public good, I would then maybe want to assume that maybe some measures were taken. So if we're going to give advice to other people or other contexts or other countries want to do the same, what advice would we give in terms of what can be done to make sure that the digital health information is accessible, but also available?
No, thank you, Joseph. I think the first thing is in any given country, if you have another platform, I mean, the advantage that Tanzania did was they took advantage of another platform that was already there. So building from scratch, it takes a lot of time. So they didn't do that. They approached it like, let's build on what is already exists, what is working. So one of the platforms that was there, like I mentioned, they build on that. So any country should be able to do that. Look what is there. Do you have specific things that you can build upon? For me, that is a very important lesson we saw with Tambua TB. It's also very important to bring aspect that, when you empower a patient, when you give those tools that they need to, you have to prepare the health system to be ready. Otherwise, you're also going to frustrate and discourage the patient. So one of the things we saw with Tambua TB, when patients self-screened, they were able to start seeking care, but some aspect of the health system was not ready. So the digital tool made certain aspect easier, but also created other challenges for the broader health system. So it's very important to be ready, that we empower patients, we make sure they can access, they can get the information, but we should be able to respond when that leads to care seeking that is in a positive direction. Those are the 2 things that I can share from the Tambua TB experience.
So maybe a follow-up question to what you said, Dr. Edmund. Do you think that maybe if this information or the Tambua application is zero rated, in other words, if it is at a zero cost, that could mean also almost everybody can access it in the context of Tanzania and maybe in other countries that might want to follow suit.
Definitely, as long as somebody has a mobile phone. This was developed for the, for the cheapest, simplest mobile application. So you can imagine those small Nokia phone that everybody has somewhere there in the road. So it should be deployed to every other place. Tambua TB can be deployed. I mean, in the case of Tanzania, in the 6th region, it was deployed across the board in the rural population. Anybody who had the access to the phone, could access Tambua TB. So that, I think it's not a very complicated deployment from I think from implementation standpoint. The only thing that people need to be ready, like I said, is the follow-up. Once people self-screen and they know they have suggestive symptom, they seek care. So you have to be ready. The health system has to be ready, whether the community health worker, whether the healthcare worker at the facility, to follow and provide the care that this client is seeking. But the technology itself was not the most complicated part in its implementation.
Sure. Then obviously you showed us a very interesting graphs where there was an increase in self-screening, but mostly among men. Then I would have wanted to assume that maybe it's because men traditionally they don't do that often, but given that technology is non-intrusive, then they are encouraged because nobody sees them. But my question also be: is it not because the boys with the tools? So in other words, men still have control over these digital resources. So because you're on the ground, you understand what happened. Is it to do about ownership and access to digital tools, or is it actually due to men's seeking behavior? Because now nobody sees me, then I can always use this tool. What do you think?
All of the above. I think it was a combination of things. Particularly in TB, men don't come to the facilities. I mean, we have seen across the board for a number of studies, men don't seek care for TB. It is they report late all the time, or they don't come at all. So did this tool make it easier for them to do that? I think so. Did this reach at the point where they feel like nobody knows my status? The stigma aspect that Monica was alluding to. I think there's part of that, but it also, it could be possible that they have the phone more than anybody else. But at least in the setting we did, the Tambua was deployed. That was not the issue. I think mobile phone were, in terms of ownership, were equally owned by both male and female. But it could be some aspect of the care seeking that men, don't necessarily find time to go to the facilities. The facility are operating when they're working, and that make it harder. So this made it easy in terms of access, but also the information that was sent, I think maybe empowered them in a way that they said, okay, maybe I can deal with my TB without necessarily wasting a lot of time just sitting there at the facilities the whole day. There could be some aspect of all of that. And we saw a number of those. Over.
Sure. Then obviously to Monica, because Monica, you were coming into Tanzania. I'd assume that you are kind of an outsider, bringing a new perspective or maybe seeing things. So what is it that you saw in Tanzania, even as you did this TB research, but also, I mean, without putting you on spot, but research is normally done by people. They could be men, they could be female, but here you've got a female researcher coming to a context where maybe men like hiding their health behaviors. What can you tell us about what you saw?
I think that's a very good question, Jonathan. One of the things, as an outsider, I'm not from Tanzania. I've done a little bit of work in Tanzania. I think my observation has been general, what I've seen in India and other places as well. Women tend to be in the health systems relatively more because they seek pregnancy care, antenatal care, child care, and men in most countries in rural areas and semi-rural areas do not access care, as Dr. Edmund strengthened. And also it's one of the places, it's also that macho thing that, I'm a male and I might not, even have TB. And I think that's why the self-application or self-evaluation apps are helpful, because you get the diagnosis, you get the, some data that if these are the symptoms, it is private, it is not stigmatized, and, people can seek care. This is one of the things we are trying to, I think that will be helpful for TB if we can remove the stigma and make it more personalized rather than inviting people into, a health center and screening them. I personally feel giving them the personal space and removing stigma will be one of the very strong parts.
Thank you, Monica. So that quickly gives us opportunity to allow our participants to ask some questions. We've got one question coming from there's an anonymous attendee. How can we encounter health disinformation and misinformation in the digital space? So just to both of you.
Go ahead, Monica.
I think what I would say is that, yes, disinformation can be, especially with internet and digital technology. But I think if there can be trust built that, this information was, created or information is produced, trust and confidentiality, and making sure that the information is correct, it is updated. I think we will have to start from a little bit, trust and making sure that the information is correct. Those are my two things to make sure that people trust and use the systems more efficiently. But Dr. Edmond, you want to add anything else?
So Joseph, I think that question is really relevant. People get, you can, if there's nothing else there to counter the misinformation, then of course they face and then they become the norms. I think one of the things that Tambua TB was designed to do was sending these small bites of correct information about tuberculosis. Not everything that you have, this particular syndrome, that particular syndrome is TB. I think they're giving the correct information. So in a very small text message, the Minister of Health was able to push this correct information. What is TB, what is not? So in that way, I think we give the information to the people in a way that if something comes in and with the misinformation, I think they have some baseline to back up with. So I see opportunity, the wider deployed digital solution that focus on literacy, the more we can at least intervene or disrupt some of the information that circulate and cause a lot of harm for our patient.
Sure, thank you. We have 3 more questions, but we'll take them to the panel, to the panel session at the end. So just hold on to the questions that we have, then we do them at the end. I'll now hand over to Joseph to take us to the other session. Over to you, Joseph.
Thank you so much, Jonathan. I'll have the pleasure in introducing our last speaker today before we come to the question and answer. And our last speaker today is Mahima Venkateswaran. Excuse me, Mahima, that I don't get your complete name. You share your presentation from your background, both as a postdoc and as a worker at the public health institution in Norway. You really have the insight of what is happening and how to bring that across. So I'm really looking forward to your presentation. Thank you.
Will you share screen or should I do it myself?
Please do it. You are...
Okay. Okay. Let me... just give me a moment. Right. I think you see my presentation, but then you can't see it in the presentation mode. Okay, does that work? Perfect. Okay. Thank you. My name is Mahima, and you said that right, Joseph. It's Mahima Venkateswaran. I am a researcher and a postdoc at the Norwegian Institute of Public Health and the University of Bergen. I just saw that there is a poll posted here. So before I jump into the presentation, I just thought we could do a quick poll of the audience and see what you guys think. So what kind of an audience is this? So the question is really, what do you think? Digital health, is it creating challenges to health and health literacy? Or is it providing opportunities to tackle health and health literacy? Because I think we heard different perspectives and very nice presentations on actual on-the-ground projects. So I just want to know what you think, what the audience thinks. We can come back to that, of course, later as well. Okay. All right. Okay, I'll give you some time to go through that poll. But in the meantime, I can tell you that in today's presentation, I will be building on the presentation of the two previous speakers. But then I will also zoom out a little bit and actually talk about the global perspective on how to think of health literacy in this time of digital transformation, and also provide some recommendations for the way forward based on what I read and based on the scholarship that's out there. Okay. Here you see the share of the total population in the world that is actually using the internet. And as you can see, the trend is increasing, going upwards. And this is common for all countries and regions of the world. There's been a huge increase since the beginning of the millennium, and this trend keeps increasing. However, you also see that there is a huge difference between what's going on in the more developed parts of the world versus what's going on in the lesser developed parts of the world in terms of the percentage of the population using the internet. Now, this is the mobile phone subscriptions that we also heard a lot about. A lot of promise. It's a simple tool. It's a simple, relatively simple digital health intervention to set up. Essentially, the darker the shade, the higher the mobile subscription. And you see that there are very, very few countries in the world that have a lighter shade. So you can see that the majority of the population is somewhere between the 7,500 mark. And this is the subscriptions per 100 people. So you see that this mobile phone ownership, at least, is becoming near universal. Now, for the more advanced digital health interventions, which we have not exactly talked about in the other presentations so far, and these are, for example, precision medicine, artificial intelligence, to enable two-way communication, etc. This issue of high-speed internet comes in, and this is a map that shows the status of the landline internet subscriptions or the broadband systems that you typically need for these interventions in different parts of the world. Now you see that the graph has become significantly lighter in shade, and the divide between the more developed countries and the less developed countries, the resource limited settings, is now becoming more obvious. So the poll was about this. So digital health, is it actually a challenge or an opportunity? It can range from a wide variety of things, including, for example, apps, SMS messaging, digital health records, information systems, but it can go up until wearables for personalized medicine, gives you, tracks your heart rate and tells you how your health is. It can transmit information to someone else, to more advanced digital health systems such as artificial intelligence. The reality, of course, this is that this is a tremendous opportunity to do several different things. We heard great examples of what is actually being done, even in settings where there is problems with internet, even in settings where there are problems with access. It is still possible to do some things with digital health interventions, particularly towards maternal health, family planning, infectious diseases, as we just learned, but also in other fields like agriculture and so on. Especially during COVID-19, telehealth became a big thing, but these also have some implications to it. But the real challenge to digital health, and in the context of health literacy, is what happens to health equity. Now, in those maps, I showed you a comparison of what happens in different regions of the world, but in reality, what happens within country is also equally important. There are different lines of digital divide, such as socioeconomic groups, age, gender, etc., which play a significant role in using digital health interventions. On the other hand, the information landscape is also changing tremendously, right? So before, the main sources of health data were health records. I've had it digital here since more and more countries are using digital records. But now you have internet, which has really democratized knowledge, but it has also come with several challenges, such as, when we have an illness, when I have something, for example, the first thing I do is to Google my symptoms, right? So this also plays into how do you judge information? How do you judge misinformation? How do you judge what the right thing is? Social media, of course, is coming in as well, plays a very, very important role. This is to say that there are alternative channels and ever increasing alternative channels to get health information, other than the traditional health system, healthcare provider to the client exchange. So what's happening essentially is from a lack of health information to a complete overload of health information. And in this changing landscape, with the given opportunities we have with digital health interventions, we really need to think about how we deal with it from a systems perspective. So we had our first presenter that presented very nicely about the definitions of health literacy. And now I would move it further to include digital health literacy as well, which was also presented. So it's essentially the ability to seek, find, understand, and appraise health information from electronic or digital sources, but it doesn't end there. This person or the population should be able to apply the knowledge gained to addressing or solving a health problem. What this essentially means is digital health literacy is a combination of digital literacy and health literacy. And according to some scholars, it's also a combination of civic literacy, which essentially means what you do as a person with those information in contributing to society. So if you think of the COVID-19 pandemic, then you know that the individual's actions based on the information that was conveyed to them became very crucial for the community's response as a whole. So in 2021, the Lancet published a commission report on governing health futures, the focus of which was how do you redefine and how do you rethink health systems based on this digital transformation that we are going through. Children and young people were at the center, or they are at the center of this digital transformation, and they were portrayed as such. They are also important targets for improving digital literacy, for optimizing digital literacy, which is already increasing, and therefore ride on this wave to also improve digital health literacy. Okay, so in terms of the recommendations moving forward, I have 4 points. The first one in understanding digital health and digital health literacy is how we frame this. From being on the sidelines, from being as something that supports health systems only, from being as something that is implemented within a certain health facility or for certain groups, we're now moving into a space where we're trying to redefine health, digital health, as an integral part of universal health coverage. Scholars have defined digital health literacy as perhaps a super social determinant of health. And digital literacy as defined by, for example, access, skills, connectivity, and so on, has direct impact on so many social determinants, if not all the social determinants of health, that it becomes an integral part of it. For instance, healthcare system, what we eat, how we think of what we eat, what we learn. The COVID pandemic is a great example of how schooling almost overnight became online, and this came with its own set of challenges. It was a great opportunity, but it was also an evident, it was very evident the amount of health inequities in general, and therefore on health as well. Where we live and where we choose to live and how we live, it also has a direct impact, or it has a direct connection to what kind of people we are friends with, what kind of, who do we vote for, right? and as well as how we think of money, what happens in a society as businesses become more and more digital. There is going to be increased growth, and therefore some regions or some sections of the population might be left behind than the others. So these are the different social determinants of health, and this is to show the connection between where digital literacy stands in this landscape. The second aspect to think about is governance. All the speakers stressed on this in terms of policy and what needs to happen for these smaller pilot level projects to actually scale. One of the first things that has to happen is understanding of digital health, as well as digital health and the literacy aspect that comes with it, as something that should be publicly driven, and it cannot be private for-profit only. Health for all is the principle in universal health coverage, and digital health should also follow these principles. For example, a start could be that health systems actually have a digital inclusion focused strategy, making sure that different sections of the population are not left behind as a result of this digitalizing healthcare, as a result of digitalizing the whole system. The third aspect is thinking about the way we collect, use, and manage data. This was also touched upon in the practical work that our other speakers are doing. And this, for far too long, and this continues now as well, most health data is collected within health systems. They're not managed, they're not shared, and this cannot be sustainable moving forward, especially because patients now have access to an alternative data source through the internet. So data management should be based on both individual rights and privacy, putting the clients at center, but also based on the principles of data solidarity and allowing for data sharing. Health data is a public good, and it should be treated as such. It can no longer exist in silos, as was very clear also in the COVID-19 pandemic situation. Investing in the enablers of digital health is extremely important, not just internet, as we saw earlier, but also in workforce. The skills of the health workforce needs to be updated all the time, especially with new technology coming in. They're an important link between the introduction of a certain technology and the clients, and they act as mediators for both adoption of technology, but also how to act based on the health information. In order to do this, we cannot do it project-based, and it has to be country-owned, because these are huge issues, and these are the actual building blocks of the health system that also need to be addressed. So I have a short summary slide just coming back to what we do in our everyday life and how we run our projects, how we run our research. Again, it's a summary of the different important points that the other speakers have already raised. For example, when designing projects, one of the first things to assess could be the digital health literacy. And this applies to whether you're looking at a project of digital health interventions, or if you're looking at a project of doing something else, because we are in a position where we are going to use a digital tool for data collection, for delivering the intervention, or something else. It's become such an integral part of so many projects. Now, it's not only important to assess it among clients, but it's also important to look at health workers and where their health literacy and digital health literacy stand. Based on the assessment, we select the right digital health interventions. There are so many, and there could be existing ones versus new ones. And especially when new ones are considered, you need to revisit what the level of the recipient is, what kind of interventions are the clients used to, what can care providers handle. Selecting implementation strategy is equally important. All our speakers here will, I think, vouch for this, that digital health intervention projects are not just tech projects, so to speak, but they are behavior change projects. And they take quite a bit of effort to move from just technical implementations to actually achieving behavior change. promoting the use of technology and adoption of technology is equally important as the first implementation. Community organizations such as community health workers have played a tremendous role in many of these settings in order to deliver the interventions and in order to support the users with using these interventions. And public-private partnerships could also be important. They are important in many health system settings because of the way healthcare is delivered, but also because of the way digital health is thought of and delivered in many of these settings. Thank you.
Wonderful. I really loved your input, Mahima. Thanks a lot, and thanks a lot for your summary. Would you mind to bring it back to us again as the starting point of the discussion? Because of course, just one slide back.
Yeah.
When you started and showing the internet use, my first question is, well, I've seen these numbers. I've seen that how ITU and so on present the numbers, and it's basically what is access to internet for someone south of Sahara African. Right? Facebook is internet, and internet is Facebook.
Yeah.
So it's at the end of the day, it's a lot of, well, is internet more than WhatsApp and Facebook? And how do we bring digital health really as internet out? Because I still, when I see the numbers and I work with the numbers, I see that, of course, ITU loves to show that everyone has internet. And that one forms the result of what's coming out. Any comments from your side here?
Yeah, so if you look at more graphs on the same topic, different indicators, you see that people use internet mainly for social media. And I think Facebook tops it, right? So this is true. What the internet is being used for is a different question, right? But the idea that, well, which is why I showed the graph on the broadband internet connections as well, because you would typically need much stronger or better internet if you were to implement or roll out any of the more advanced digital health interventions than just basing it on social media, for instance.
Yeah, I really like, I really agree on you. When you talk about inclusion, I really feel that like inclusion is our biggest challenge when it comes to the internet, because like we are only representing two of the things, like audio and visual. But we are not presenting enough of the other skills. Any recommendations of how that could be addressed?
I think the first step would be to understand what groups we are dealing with, and what do they mean when they say they have a phone, for instance. What does it mean, like you say, when they have internet? Those are, it's more nuanced than just understanding if there are some groups that have access to a phone and some groups that don't. So in thinking of digital inclusion, one also needs to understand how culturally things work as well. For example, in one of the projects that we had in Bangladesh, the initial assessment was that everybody had a phone. They actually showed us that they had a phone. But then in reality, it's not, they didn't have control over what they were reading on those phones, for instance, and if they were able to act on that information that they're getting. For example, come more times to antenatal care, for instance. That was not a straightforward connection between the two. So it's, yes, so I think when we talk about it, it often becomes like these are certain groups that are left out, but then even within those groups, that it's more complicated than that.
Wonderful. In the interest of time, Mahima, there's a very, very interesting input, the last one in the question and answers, that we are completely on the demand side and not really missing the supply side. Maybe that's a point from your public-private partnership and how we could address that.
Yeah, I'm just reading the question. Yeah.
Yeah, it's a long question. If you start answering that, and then I will open up the floor to Monica, Edmund, and Margaret to maybe start with that question, because I really feel that that question is a very nice question to help us in moving further with what we want to achieve. As I know that everyone can read it, then I would just take that as an example. And while you are doing that, what I hopefully have shared with all of you, the strategies, or what I summarized from the seminar. Now, I don't want to go too much from the lessons. Oh yeah, sorry, Mahima, I didn't want to stop you to answering that question.
I was okay. I have a couple of thoughts and comments, I think. So first of all, we are not all from the global north, just to be clear. I think we are quite balanced in terms of our affiliations, at least, with Margaret and Edmund also with us, and with the rest of us also having, I assume, majority of careers working elsewhere. But that was one thing. But I was wondering what this person, I can't see a name, but what is supply side perspective?
Yeah, I understand that. In the interest of time, I understand that as saying that we know we want the information, we want to have the public ownership of data, but that doesn't really bring the money for the Googles, the telecoms, the others to actually pay and invest in creating the money. And it jumps a bit back into the story what Edmund presented with the discussion we had on the information page on TB, because it actually points out who is creating this information, how can we contextualize that to other countries, and how can we make it available like in Kenya or other parts. Monica, Margaret, Edmund, please jump in here. So it's a very interesting one on how can we bring up the supply side.
I'm not sure that I understand the question. Is it the supply side in terms of the health content, or is it the supply side in terms of the technology? Because if it's technology, we are disadvantaged. You know, we don't manufacture the phones, we don't manufacture the equipment. We rely on what is already available, and we use it to create content that is hopefully relevant in our situations.
Yeah, if you ask me, I'll see that really as one of the big games is that, Mahima, you mentioned that the money is in the private businesses. And that means we can't really have the, Edmund, I think the point was, no, sorry, Margaret, came from you saying that we expect 15% of the budget. We see realistically only like 6% used in Kenya. And I know from discussions in Tanzania, we are about the same kind of dimension. So the question, yeah, Edmund, please.
I think this, I'll try to answer. I'm not sure if I understand the question correctly, but I mean, you need investment for this type of, I mean, anything really. So as long as the government does not invest on this, this will continue to be primarily driven by donors. And I think one of the challenges you see with this pilot is just because of that. But I think in places where we work and where we've seen when the government actually takes it, you know, when you achieve scale, the cost for managing larger system when they are managed and governed by the government, tend to get better and better. Integration tend to be possible. Interoperability gets, I think there's a chance for interoperability, but I think I see a lot of this being driven by donor because they just want a particular point, a particular disease, a particular, and I think that's maybe make it harder for longer term investment. But we have also seen, even in sub-Saharan Africa, government invest in some of these systems. And when they do that, of course, that the initial investment have come from whatever donor. I'm sure Joseph, you've worked with many countries with when it comes to health information system. It is at the scale where now the government is invested because they can see the value from at least making sure they make available the healthcare worker to support the system. But a lot of these other disease-specific deployment have been very tinily focused on the interest of who is paying for that. Maybe that's the issue. But once you have the government interest in the governance, I've seen some changes, and it is different across the world. Over.
Yeah, thank you so much. In the interest of time, we have like 3 minutes left. I'd love to just show you what I picked up. I picked up the main lines from Margaret of the context awareness, of the community volunteers and the sharing, the connectivity and the collaborations. From Monica and Edmund, I picked up that we know how things work, but we have challenges with bringing it up to the scale up, not only in the one country, but in all the countries we talk to. And the preparedness of the health system was actually a very much a very interesting link to what Mahima said on the knowledge update. Please join me. So that brought me up to the SSA's perspective on health access, which again is linked to what also Margaret has said. The last topics, we are going to prepare a follow-up seminar. I just wrote to you in the chat that I hope that we are allowed to send you the Q&A answers, and that we are there also asking you whether there are specific topics. I really enjoyed your Q&A, even though you couldn't join in audio. I hope you feel that your questions have been addressed, and thus I'm looking forward to the next seminar series as a follow-up.
Just to add, and maybe just to thank all the panelists and the participants. So obviously the debate around technology determinism and the rational approach to health and everything also remains a debate in the West. I mean, the COVID pandemic has shown us that there's no one way to solve the problem. And we are still debating about these issues. So it's not only Africa, or it's not only the global north, but these issues are everywhere. So they are prevalent within the universal system. How we arrive at these solutions might depend on the common approach that we take in our context. As Dr. Edmund said, that the context becomes important. So we are not blind to the fact that health happens within a context. And these are the critical debates and discourse that we must continue to have.
Jeanette, please.
Thank you very much. And thank you to Joseph and Jonathan for being our guides. And thank you very much for the speakers representing such a great platform of digital challenges related to digital health across the globe. And also, thank you for you listening in and your very important questions. And as Joseph said, this is the first in a series. We really want to build a momentum because we believe that health literacy is extremely, extremely important. And we do not regard that the Northern perspective is the thing that has to rule here, and we do not think that the Google doctor is the one that is going to be the main guide or setting the agenda going forward. So please help us, join us, share with your colleagues, and pay attention to emails from Gabriella, and sign up from information from the Center for Global Health, and you will be able to listen into new seminars related to this aspect and also to others. So thank you very much for an interesting seminar, and have a blessed afternoon to all of you. Global Health hyphen at uio.no is where you can follow us. Thank you very much, and have a good afternoon.